Namaskar. Swagatam. We would like to welcome you all on our 486th milestone of brainstorming journey, AYUSH SAMRIDDHI International Webinar Series. I would like to welcome Professor Vishnu Prasad Sharma ji, Professor V.K. Agnihotri sir, Professor Madan Thangavelu sir. Welcome. And both the speakers. I would like to communicate my sincere thanks to Dr. Kuldeep Kumar Pandey sir for introducing Dr. Anil Kumar, and would like to welcome Dr. Harish Verma ji, also who is President Canadian College of Ayurveda from Canada. Welcome sir, welcome. Welcome Jayesh ji after a long time. Welcome Devashish Bhattacharya ji, Deepti ji, Archana ji. Welcome. It is very great pleasure to me that one name came directly approaching to me on radiography, Dr. Archana Muralidharan. First name came to me directly through Rajeshwari ji also for Dr. Muralidharan, and then Dr. K.K. Pandey ji introduced Dr. Anil Kumar from IMS. It is very unique subject, sir. Today is World Radiography Day, International Day of Radiography. So, by three names, this day is being celebrated. Previously, our Maharshis have much enough experience because there were no orthopedic surgeon, there was no physiotherapist separate. So all things, all examinations or all treatments were done by one single Vaidya. Right from fracture healing to cancer, only one Vaidya was there. So they had experience. But young generation didn't have the experience of reading X-ray even. This is the difference. They were reading human body without X-ray. They were diagnosing fracture and cracks without X-ray and treating those fractures or cracks by our natural healing methods. Modern also cannot do anything. Only plaster or immobility is the treatment. So very unique subject. Without being a wall between you and speakers, I would like to invite Professor Vishnu Prasad Sharma ji for his welcoming blessings. Welcome, sir. Welcome.
Namaskar. Good evening to everybody. Respected Professor Madan Thangavelu, respected Professor V.K. Agnihotri, respected Dr. Pawan Kumar Sharma ji, distinguished guests, eminent speaker, ladies and gentlemen. I, Professor Dr. Vishnu Prasad Sharma, welcome all of you to this evening webinar on important subject, radiography essential for AYUSH. So in this evening webinar, we have eminent speaker, Dr. Anil Kumar, Assistant Professor, Department of Shalya Tantra, Faculty of Ayurveda, IMS BHU Varanasi. I welcome you, Dr. Anil Kumar. Next, I want to welcome Dr. Archana Muralidharan, Department of Shalya Tantra, second year PG scholar, Amrita School of Ayurveda, Kollam. Yes, I welcome you to this evening webinar on radiography essential for AYUSH. Once again, I welcome all the eminent speakers, distinguished guests, ladies and gentlemen, to this evening webinar on radiology essential for AYUSH. And it is now, no doubt, in ancient time, Ayurvedic people, without doing any X-ray, they do that treatment. Now we want to hear from the eminent speaker regarding it is essential or not for AYUSH people regarding diagnosis. So once again, I welcome all the eminent speaker, distinguished guests, ladies and gentlemen, to this evening webinar. Thank you. Namaskar. Over to Pawanji.
Thank you, sir. Thank you. Today, after a long time, I would like to hand over the charge of moderation to Sir Madan sir. But before that, for initial blessings, I would like to request Dr. V.K. Agnihotri sir for initial blessings. Then today, I am really overwhelmed that Madan sir is with us. Welcome, sir. Welcome.
Thank you. Thank you. Namaskar, sir. He is with us right from studies itself, and he will remain with us. And he was with us. May it be his very other business. He was very much with us. Thank you, sir. Thank you. Namaskar. As we all came to know that today is the International Radiography Day, and we, with our webinar 468th, going to celebrate this in a wide manner, or rather online manner. As rightly told by Dr. Pawan Sharma ji, after the welcome address of our Professor Vishnu Raj Sharma ji, that before the invention and this facility of our radiography, all allopaths or all the physicians, surgeons of every pathy were so competent to make a diagnosis for the happening in the body of any of the person got injured, got slipped on, or even the tuberculosis infection or anything. And we'd also like to say that even before the invention of X-ray itself by Madame Curie and Pierre Curie, it's really, we were all in such a phase where there was no such facility to make a diagnosis. We were taught in the terms of scripts and mobility or not. But again, as far as the hairline fracture is concerned, it's very difficult to diagnose. So goes the case with the cholelithiasis or renal stone. These things are now made very easy with the help of this X-rays and then our ultrasonography. So X-rays has got important, and then it came in existence the film of skiagram. So we are going to listen a lot, and I think as far as the BHU is concerned, what we recall of our student time, that Dr. D.K. Rai was there, the in charge of our radiology department, and after that Dr. Arun Kumar Sachan made his contribution. Then one of my friend, junior Dr. Surendra Shekhar Mishra of Shekhar Bandhu Osdale, he was junior to me in Rishikul and then in BHU also. He made all efforts. I visited thrice, and he was always there. And then our K.K. Pandey sir is always there, and it's what is striking in my mind. What is this? Professor Dr. S.B. Pandey, then D.N. Pandey, then K.K. Pandey. What is this? The anesthesiology is the right of Pandays. If it is so, it's again a pleasure, especially with a special reference to BHU. With all these initial words, I greet you all, and we are going to listen a lot as far as the radiology is concerned. And I'm very glad that young chap, the second year student, MD second year student of Shailatantra, really it's a Amrita College pride to for our Archana that she is going to present along with Dr. Anil Kumar. He's equally, for me, he's a young chap. So both the persons are going to boost their whole energy with our old persons, that we will see that how we are going to be enlightened by your knowledge. Thank you so much, and over to Dr. Pawan Sharma ji. Namaskar.
Sir, my point of concern is that why our Ayurvedic experts, persons or scholars are fearing to X-ray. They don't try to read. They don't try to be acquainted with the X-ray. Today also we can observe the presence of expert audience is very less. Who is really sincere towards X-ray or want to learn something are here. So how this subject can be popularized for AYUSH experts or scholars, that minimum they can read X-ray. They are dependent on the report of pathologist. What is written there, it is more important, and they are correlating that written text with the X-ray to learn. That I have observed in my...
You are very truly pointing out this thing, that we are very thin in number. It's only 13.
Yes, I do remember that means we don't have interest in radiology.
Exactly. Moreover, what we have seen during the regime of Professor Deshpande sir, way back in 1980, they used to keep at least 30-40 X-ray films and make a class of our 20 students with the help of their residents and all that. And they right from the start differentiating if the X-ray chest is there, sky-arm, PAView, then why it is male and why it is of female. Right from that thing, the pendular shadow, and apart from the clavicular, so costophrenic margin, everything is sternal. It was the starting one. And after that, Dr. Arun Sachan also having 30-40 X-rays, Dr. Sunil Joshi having 30-40 used films, just to remember. And X-ray itself film was the one of the, say, we should say, as a spotting the viva and all that, how you are going to diagnose.
So
And
I
what is
would
this?
like to request speakers also that can any course can be prepared on our online institute where X-rays can be explained to Ayurvedic scholars, because this can be done online. There's no physical personality is needed. So
X-ray,
I would like to
ultrasound and
welcome
MRI.
Professor Madan Thangvelu
Yes,
sir
sir.
from
X-ray,
our guide.
X-ray,
Right.
ultrasound, and this MRI report, these can be made easy online demonstration and all that. It will be a great event if it is going to happen. So thank you, sir. Thank you.
जी पवन जी
मदन।
नमस्कार।
नमस्कार नमस्कार हरीश सर।
पवन जी, जो आपका क्वेश्चन है बड़ा इम्पोर्टेंट है। मेरा मानना ये है कि ये आयुर्वेदिक प्रैक्टिशनर्स और आयुर्वेदिक डॉक्टर्स या आयुर्वेदिक ग्रेजुएट्स के स्कोप ऑफ प्रैक्टिस में नहीं आता है। यू कांट मेक रिपोर्ट्स ऑफ एक्सरेज, एमआरआईज और सीटी स्कैन।
नहीं, मेक की बात नहीं कह रहा सर, मैं रीड की बात कह रहा हूँ, मेक नहीं कह रहा हूँ मैं। आई एम नॉट आस्किंग फॉर मेक। Read, even read.
Learn and read. Yes.
Nobody is able to read. They are totally depend on the text, whatever the unskilled pathologist has been written. So I would like to request Madan sir for his valuable moderation. Thank you, sir. Thank you very much. You are mute, sir.
Pawanji, namaskar. Thank you for bringing us on the 485th webinar today. Thank you. Welcome all to the platform. Anilji, namaskar. Archana, namaskar. Archana, I've been troubling Archana saying, thoda sa, if you can put a little bit of light on your face, then we can all enjoy you better. Because our recordings are, our presentations are being recorded and students can come and learn from it in the future. So, number one, I'm going to quickly go into this topic with one or two examples. So Agnihotriji, what Agnihotriji has said and what Harishji has said and what Pavanji has said, which is at least the students must learn how to analyze, interpret radiograph. And there are many resources here. I'll do a few screen shares so that we can set the tone for some of our discussions, and also our speakers might be able to tell us a little more. Here is the resource that is available to anybody, any part of the world, Radiopedia. And shown here are images available to all. And I've started with COVID-19. And this is and there are different cases listed here, so many cases for COVID lung radiographs. Okay, so that's one. And you can click into any one of these things and you will see what a lung radiograph would look like. And you can zoom in, zoom out, and you can see many, many resources. Number two, I want to touch briefly, I will put all the links on the chat box. Number two, I want to touch briefly on avascular necrosis of the femoral head and radiology. So once again, I've used a search string here, avascular necrosis of the femoral head. This is a big problem these days. And the reason is most times excess use of steroids. I think Anilji would have seen many cases of this. Many people see this, and certain medical treatments also give rise to this. And again, I'm just looking at resources available to all: avascular necrosis, osteonecrosis. And in terms of Ayurveda, here is a paper from 2016. This is a paper from the Department of Panchakarma in Patanjali Yoga Peeth in Haridwar. And it's the role of Ayurveda in the conservative management of avascular necrosis of the femoral head, a case study. And if you look within here, it talks about the Astivaha Shrota Dushti Vikara. And then it talks about the Gambhiravastha of this condition. And then it goes on to talk about the Shodhana and the Brahmana treatments. And it lists the procedures that are used. So it uses some Basti, it uses Pindasveda, and it uses, again, Manjishta-based Shirabasti, etc. And it does the results here. Now, once again, if we go into the radiological analysis and you want to learn a little more, then here is, go back to Radiopedia, you can see the resources. And just one image from here for students, just for students to understand, shown here is one image, and it shows one section. Shown here is the damaged femoral head. Now, if you go back into understanding, trying to ask why this problem, then Ayurveda provides a lot of information, a lot of valuable knowledge on how to revive this condition, and particularly how you do very interesting Basti-based treatments and cleaning the system, Panchakarma. And we look forward to learning from our scholars today how they see this. This is only one example. So I've shown avascular necrosis of the femoral head as one example. There are so many other conditions where if we had that tool, we are extending the reach of our indriyas. That is all we are doing with a new tool. Then we can see a little more, we can understand how the treatment works, and we can refine the treatment too, perhaps. So I leave it there, and we look forward to learning from our scholars here. Anilji, thank you so much.
My desire and hope with the experts of radiology, Ayurvedic radiology, is that, sir, again, I would like to repeat my words. If we can, by this Radiopedia also, it can be done along with that. If we can plan any short-term course for interns or final BMS students, it will be a great, really benefit for those students who will be confident for reading radiology, not creating, reading. So, with these words, I would like to invite Dr. Anil Kumar, Assistant Professor, IMS BHU. And thank you, Dr. K.K. Pandey. Thank you very much. Dr. Anil, you can share your presentation.
My slides are visible, sir?
Yes.
Yes, slides are visible. You can go for slideshow to maximize the size of slide.
Yes, sir. First of all, I would like to thank the organizing team for providing me this opportunity to interact with you all. Before I start my presentation, I bow my head to Wilhelm Conrad Röntgen, who discovered X-rays and got Nobel Prize for that in 1901. The topic for today is the need of radio diagnosis and imaging in clinical practice of Ayurveda. I am often asked a question from my contemporary colleagues: is there any evidence, any reference that you can show based on which you can say that any imaging modality was available before the advent of modern medical science? Here I have quoted a Gilgit manuscript, 5th to 6th century AD, where there is a description of a neurosurgeon, Jivak. We all know that Jivak, who performed surgery on brain and removed a lizard-like thing from the brain of King Bhoj and saved his life. Jivak was physician to Lord Buddha and King Bhoj. Now the question rises, how could Jiva come to know that there was a lizard-like shadow in the brain? There was some sort of imaging modality available at that time also, I would say, based on which he decided to operate the An example we can see over here in Susu Samhita in Bhagna chapter. There are so many fractures which are not the overlying skin is intact in that fracture. But Sususa has explained that fracture is curable and incurable. That Sandhimukti is curable and incurable. There was some sort of imaging modality based on which every Susuta has decided to quote it whether it is curable or not curable. Also, the presentation of mood garb in Susuta has presented mood garb, 8 types of mood garb. How could he come to know that the fetus present in the uterus is lying in such a position? There was some sort of, I think, imaging modality available at that time, but which gradually lost with time. And unfortunately, we lost everything that was present before. But today, a question arises: need of radio diagnosis. Is there any need of radio diagnosis in IUN system of medicine? I would say yes. Today, people question about the scientific validation of IU system of medicine. We prove ourselves clinically, but people are not going to accept it if we don't prove ourselves on scientific parameters. If we treat patients who are suffering from chronic renal conditions, and we say that patient also get benefited with that with our treatment, but we don't have any evidence what anatomical changes come in kidney after our treatment. For that, we have to image the kidney, and for imaging the kidney, we have to use the modern tools, radiological tool, to prove ourselves on scientific parameters globally, to prove ourselves globally. We treat joint disorders, very rightly said by one of our sir sitting there, that femoral head necrosis. There was femoral head necrosis, and one of our Ayurvedic practitioner treated it. But how to document it? To document it, to let the people know that what we are providing, what treatment we are providing really works, and really works, we have to use the modern tools. Modern tools are developed by biomedical engineers, not medical doctors. So incorporating those tools in IO system of medicine is very mandatory, very important. We should not abstain from that one. Now a question rises also: treatment based on clinical evaluation only. Is it always possible? Clinical evaluation is very much important, but along with that, if we have any doubt about the diagnosis, we should go for the diagnostic tools available nearby to confirm the diagnosis, because diagnosis and treatment strategy both are equally important in the successful outcome of any treatment. If we have diagnosed the patient wrong, there won't be any success, whichever treatment strategy you use, whichever surgical skill you use, there won't be success. But if the clinical diagnosis, and if you confirm the diagnosis through any investigative tool, and then we plan the surgery or any treatment accordingly, then the success becomes inevitable in that case. The keynote, the center point of all the pathies for treatment, all the pathies, is final diagnosis. If the diagnosis is made correct, then all the pathies will be able to treat the patient properly. If diagnosis is not correct, then nobody will be able to treat it. And what is the importance of diagnostic aids? People are very literate, very conscious now. They themselves want a diagnostic tool. They themselves want to get diagnosed with a modern tool. It is for patient satisfaction. We can choose the treatment plan accordingly based on the diagnosis. We can initiate treatment at earliest possible. We can avoid the late complication. For medical legal purpose, we have to document it. We have to keep the records. For future record and follow-up, we should go for diagnostic aids. Radiology is a very vast topic, so it won't be possible to complete all the topics in a single lecture. So what we practice in our department at Banaras Hindu University, I'm going to show you those things only today. So we practice, as very rightly said by Sir, X-ray. Dr. D.K. Raj has set up the radiology Vikiranam Chhaya unit in Shalyatantra department of Banaras Hinder University. I am the in charge of that particular department. I perform X-ray fistulogram, report it, and I also perform transrectal ultrasonography for the evaluation of anorectal disorders, especially fistula in ano. So here I would like to explain first the X-ray fistulogram, what I use. With these two modalities, imaging modalities only, I am proud to say, I'm happy to say that annually more than 30,000 patients who are suffering from anorectal disorders visit our Department of Shalyatantra OPD. More than 30,000 patients. The reason is we evaluate, if we have any doubt, then we go for X-ray fistulogram, transrectal ultrasonography, MRI. Systematically, we have a protocol altogether through which we proceed to diagnose a fistula in ano. Then we operate it, because once the fistula is diagnosed properly, and Chara Sutra therapy is very well known to all, that it's the best of the best therapy available today for treatment of fistula in ano. If the diagnosis is made correct, then the recurrence rate will be less and less. If diagnosis is not correct, there definitely there will be recurrence. Once the recurrence has occurred, then the anatomy of that particular anorectal region get distorted, and that's a region which have a very complex anatomy. Once it get distorted, then evaluating the same fistula, recurrent fistula, clinically becomes very difficult. Even radiologically, it becomes very difficult for radiologist. Here we use X-ray fistulogram. The first diagnostic modality that we use is X-ray fistulography. We don't use the conventional X-ray fistulography. We use Deshpande technique of double contrast X-ray fistulography in our department. Since 1974, a modified form of X-ray fistulography, also known as Deshpande technique of double contrast X-ray fistulography, is being practiced in Banaras Hinder University, Varanasi. Deshpande and his colleagues developed this technique where they used a air-filled balloon placed inside the rectum as the second contrasting agent, along with metal markers fixed at anal verge and external opening. I will show in the next slide how it happens. The technique is far beneficial over conventional fistulography because here fistula anatomy can be interpreted very well in relation to the anal canal, rectum, anorectal junction, and other anatomical landmarks, which gathers more precise information about the fistula. See, AYUSH practitioners are usually practicing in rural areas where MRI and other transrectal ultrasonography, these sort of sophisticated instruments, equipments are not available. But this Deshpande technique of X-ray fistulography can do a magic. If it requires a very few articles, very few other articles easily available today. With a little bit of customization in X-ray fistulography, we can perform this Deshpande technique. It's very easy. So for rural areas where only X-ray equipment is available, this Deshpande technique can do a magic, provided it is known to everyone. See, the articles that we use is a Melicote catheter, a balloon, maybe a condom can be used, a metal ring, a sphygmomanometer bulb, a syringe, infant feeding tube, a metal to the anal verge also. These are things which is only required or very easily available today. These are used to perform this Deshpande technique. See, this is first slide A, first picture, which is A. Slide A is plain X-ray fistulogram. Here we cannot comment upon any what is this air shadow, what is this air shadow. But in the Deshpande technique of contrast fistulography, we can see this is an abscess, perianal abscess, which is extending to the gluteal region. This is another picture of X-ray fistulogram. Here you can clearly see this radio opaque shadow ring, which is kept at anal verge at the time of performing radiography. And this another metal ring is kept at the external opening of the fistula. Here, where the balloon starts deflating, when balloon start inflating, the air shadow starts to form. The space between this ring and this air shadow, where it starts from, is the anorectal ring. Is the length of the anal canal. This is the anorectal ring marked by yellow arrow. We can here we can comment about the length of the anal canal. We can see the fistular tract is traveling left side of the anal canal, and track is going midline and smearing on the balloon. With this, in the lateral view, we can see the Malicote catheter is dividing the anal canal into anterior and posterior half, and the radio opaque shadow, that is the dye, urethral dye we use, is anterior to this Malicote catheter. It means it is anterior fistula. In conventional fistulography, we cannot comment easily whether it is anterior fistula or posterior fistula. So it is anterior fistula with midline extension, and internal opening is there in the midline at 12 o'clock position. Here we can comment upon the length of the anal canal, presence of anorectal ring, internal opening, and extension, any other extension of the fistulous tract. Every sort of information we can gather from simply this Pandit technique of fistulography. If the tactic does not provide the essential further information, then we can go for the MRI and other sophisticated tools. Otherwise, majority of the cases, in majority of the cases, X-ray fistulogram is sufficient. There is another equipment we own in our department is transrectal ultrasonography. It has a 360-degree rotating anorectal probe, which on calibration is inserted into the rectum, into the anal canal rectum, and the images are taken. See this hypoechoic image marked by the white arrow that looks a little black is internal sphincter, and this hyperechoic after that ring is external sphincter. This is the axial view of the transrectal ultrasonography image. Another image you can see, this is the puborectalis muscle, puborectalis sling, which eventually becomes the levator and eye muscle. This black shadow is the internal ring. This is the internal anal sphincter. This is the external anal sphincter. This is the water, which is balloon has been used in this also. So this is a water phase interface. This is the probe. Ring is the probe. This is a case in which you can see it is this hypoechoic lesion. It is intersphincteric fistula, which is showing an intersphincteric fistula. This red arrow is marking the internal sphincter. There is breach in the external sphincter, the hypoechoic breach, that suggests it is intersphincteric fistula. This is a transsphincteric fistula. You can see there is breach in the internal sphincter and the external sphincter. Track is traveling, crossing both the sphincters. This is the puborectalis sling marked by the red arrow. This is a very good sophisticated tool. We all the faculty of our department perform it very well. They all are blessed with this tool, and Professor Manoranjan Sahu sir has taught us everything about this transrectal ultrasonography, and we all perform it. Sometimes patient is operated multiple times at different centers, and he comes to you and say that I am not able to hold my stool just even for a second. Then you have to take a consent from that patient, and you have what we have done. We have performed ultrasonography and shown this patient that your sphincter is damaged, internal sphincter is totally damaged. So the problem that you are having will still be there after operation. If you are ready to get operated, if you agree, we will operate you. Otherwise, we will not operate you. This is what you can take the picture and document the patient. After that, patient will not complain, that not sue you any court that I was okay before operation and thereafter this incontinence problem exists. This is another case. Patient there was perineal discharge from the patient. We are looking for whether there is a fistula or not. We performed anorectal transrectal ultrasonography and we found that this hypoechoic lesion marked by yellow is perineal abscess. This broad is the perineal abscess at the left side of the anal canal. So here we drained the abscess only because fistula hasn't formed here, or it will take definitely. Normally, the perineal fistula eventually develop into the fistula. Perineal abscess eventually develop into the fistula. We left the patient, and if the patient develops fistula after that, then we operate it. But main problem of the patient was the perineal abscess. So with this technique, we can actually assess what is the actual problem of the patient. This is a posterior horseshoe fistula. You can see the hypoechoic line going both arms of the fistula stack in the intersphincteric space, right side of the anal canal and left side. It is also traveling to the right, left scorectal fossa. The patient had its external opening at the gluteal region also. It is the perineal abscess. You can clearly see the hypoechoic lesion posterior to anal canal. It is also its arms are also there in right side of the anal canal and the left side of the anal canal. This case only requires drainage. Once the drainage is made on the most dependent part, the patient gets relief. If the fistula forms eventually after that, after a few months of that or after a year, then only we can treat. What people do, if there is fistula, they put a thread over here, so this should not be done at all. First, examine the patient, perform whatever modality, imaging modality you know or you have in your nearby location. Just go for that and clear the diagnosis and then perform your surgery. This is the picture of a perineal abscess. You can see in the axial image of this similar with transrectal ultrasonography. It is a perineal abscess, which is right and left side of the anal canal in the right and left scorectal fossa. First, we go for the foremost examination that we perform is distal rectal examination in the diagnosis of fistula in ano. And with clinical evaluation, majority of the cases are diagnosed very well. But if we have a doubt, is the fistula travels a diagnostic dilemma, creates a diagnostic dilemma and travels here and there, we don't find it, and our fingers is not able to reach up to that. If it is high anal, then we go for fistulogram, transrectal ultrasonography or MRI based on the patient's compliance. MRI normally we avoid, but if a patient demands, then we go for the MRI also. Here in MRI, you can see the axial and coronal images of the patient. It is transsphincteric tract with gluteal abscess. You can see that this is the gluteal abscess marked by yellow arrow. This is a transsphincteric fistula. Also, the coronal images, you can see horseshoe fistula there. Its right arm is there, left arm is reaching to left side of the anal canal. It's a horseshoe fistula. This is all for today from my side. What we practice in Department of Shalyatantra at BHU Banaras University, I have shown it to you. A part of it, we also perform ultrasonography, abdominal ultrasonography, chest X-rays, all the X-rays, ultrasonography, trans-ultrasonography, and we, at my institution, I teach my students, BMS students and postgraduate students, X-rays and other trans-ultrasonography and ultrasonography, so that they could not, they could actually comment on anything what they see in future, X-ray films and other ultrasonography films. Thank you so much, sir. That's it for today. I acknowledge Professor M. Sahu, sir. He has taught me everything what I'm delivering over here. Thank you, sir.
Thank you. Thank you, Dr. Anil Kumar. Thank you very much. Very nicely explained. Again, I am repeating my words. If you have experts, you have senior persons from radiography along with you, please help us to start a short-term course for radiography for interns or house physicians or BMS final year students. Thank you. Thank you very much.
Thank you, sir.
Madan sir.
Thank you. Pavanji, we will proceed to, I have one or two comments in response to Anilji, but we will go to our next Archana and then we will come back to the comments, Pavanji.
Right, sir. So I would like to invite Dr. Archana Muralidharan, second year PG scholar from Kollam. Welcome, welcome.
Anilji, if you can stop sharing your screen, then maybe Archana will be able to.
Yes, sir.
Thank you, Ji. Archana, namaskar. Namaskaram. If we could get a little more light on your face, then it would have been nice, but let us proceed. Let us not delay, because our
Yes, from your state, sir.
That's why.
the reason why I say this is because all our programs are recorded, and then when people come to view it again, anyway, we will continue with what you have. Thank you. Welcome.
Thank you, sir. Whether the slides sir? Are my slides visible, sir?
Yes, yes, yes.
Okay, thank you.
You can go for slideshow.
Thank you, Archana. All good.
Thank you, sir. Good evening, one and all. I'm Dr. Archana, second year PG scholar, Department of Shailendra from Amrita School of Ayurveda. I'm here to present the importance and need of radiography in our system of medicine. As we know, radiography is considered to be as a diagnostic tool. So in this presentation, I would like to highlight the importance of radiography and its need in understanding by using some examples. What all examples I'm sharing with you are the cases of my gurus. With their support, I'm here to present the topic. Let's begin the topic. Moving to the introduction. Radiology is a specialized field of medicine. It is used for diagnosis and treatment of diseases. Whereas radiography is a technology used in medicine and is for the production of images of the body organs. And mainly radiography application is for two, that is medical radiography and industrial radiography. Medical radiography used for medical purposes and industrial radiography used in airports and all for the scanning purposes. Moving to the history of radiography, in 1895, radiography, X-ray radiography was invented by W.C. Röntgen, who is considered to be a father of radiology. And in 1950s, USG and radionucleotide imaging were invented. And in 1972, CT were invented. And in 1973, MRI by Godfrey has invented MRI. And in 1977, DSA, that is digital subtraction angiography, were invented. Giving a brief idea regarding the radiological techniques, some are, that is X-ray radiography, which is used to examine bones and joints, and CT is to visualize all parts of the body and is used to diagnose disease or injury, and it also helps to diagnose muscles and bone disorders such as bone tumors and fractures. It will point out the exact location of the tumor, infection, or even the blood clot. And MRI, it is useful for certain diseases that which CT can't detect. And going for USG, high frequency sound waves are used to produce images of parts present within the body. And mammogram is to detect early signs of breast cancer. Doppler study or Doppler ultrasound is to used to diagnose and detect the blood clots, and is of two types, that is venography and arteriography. Let's see how to read a radiograph. By detection, interpretation, and evaluation, we can read a radiography. Detection in the sense, detect which X-ray it is and interpret the bones or joints, the structure involved in the given X-ray. Evaluation is made by understanding the underlying pathology, if any. And appearance of X-ray based on the structures involved, that is the basic 5 normal basic densities. Air or gas appear to be as black in X-rays. Fat appear to be dark gray, soft tissue or fluid appears to be light gray. Bone or calcification, it will appear as white, and metals will appear as intense white. These are some of the certain views in the X-ray, that is AP view, PA view, lateral view, oblique view, etc. This is one case. The patient came to our OPD complaining of pain over the foot, and she had a history of hit over the foot. And we took X-ray, and we found that fracture over proximal phalanx, and also fracture over the distal metatarsal. And also we can see sesamoid bones in this X-ray. In this case, we have to think that whether we need to go for KY fixation or not. Here we do. We are able to manage such types of fractures by giving a gentle traction, and then bandaging is done. Next is a X-ray of a child, a newborn baby, that the humerus has got fractured during his childbirth. We have to be very careful while dealing such cases, since it is an infant, so it is better to take suggestions from pediatric orthopedic surgeons, or better to do referral. This is another example of showing right knee joint, and is of two view, that is AP and lateral view. We should look for the position of the patella. It is not centrally placed, and also then look for any osteonecrosis. The osteonecrosis will appear as dark patchy on these X-rays. From this X-ray, it is clearly representing the OA knee, and osteophytes are also visible in the medial side. And also we can see that the distance between the intercondylar space is also very reduced. Next is the X-ray of shoulder joint. Here the patient came with pain and swelling, and also by taking the history, we came to know that she had a history of fall, and thus she got pain over right shoulder joint. And here after taking
Archana, we have lost your.
Because branches of axillary artery are passing over there, and any injury can lead to deformity in further. So we should be very careful regarding dealing these cases. And in this case, we give gentle traction and also do POP, and this can be managed without open reduction and internal fixation. Next one is a foot X-ray. Which showing AP and lateral view, and the patient complains of pain only, and we have to be very careful that whether the pain is due to inflammation of underlying fascia, that is fasciitis, or maybe due to pressure effect. So for that, X-ray are useful to differentiate the above side. Here in this X-ray, it is clear that the presence of calcaneus on one side, and also over the back area with pain. In handling such cases, we must get suggestions from expertise who are very expert in dealing such cases, and also better to take a USG abdomen for analyzing or understanding the current situation of the organs, that is whether they have getting pressurized due to the scoliotic changes of the spine. For this case, we have given traction initially along with the panchakarmas, and also we advise the patient to wear thoracolumbar corset also. And within a 1.5 month itself, we have seen a noticeable change, and also the hump got reduced in size. Next is an X-ray of the had a history of hold on an outstretched And this we given a general traction, then POP bandaging was done, and that showed a successful healing in this fracture. Next is a patient had a history of heavy object fallen on the foot, and that made a fracture of the metatarsal. And for this, we done closed reduction and also bandaging using splints were done, and bandaging using simple gauze bandaging was done, and it got healed by the time. Next is a X-ray of a pelvic bone, and it clearly understands that as an avian, and that too of stage 3. And in early stages of that is in stage 1 and 2, which can be set as Kristosadia by giving treatments like Dhara and all. So because we are not able to give pressure over this area, because chances of getting fracture is more common, more in this case. So in this case of in the case of stage 1 and 2, only some part of in stage 1 and 2 only some part will get necrosed. In stage 3 and 4 of avian, that is the thicker stage 3 and 4, it is more susceptible to get fracture. So before that, it is good to refer the patient and advise for hip replacement. Next is the fracture of distal end of fibula. Here in this case, mild extraction and splint bandage was done, and it got healed by the time. Next is metacarpal. Here in this case, patient had got a hit over the hand. Thus the fracture had occurred, and for this we got go for mild and splint bandage was done, and that too healed by the time. Next is the radial head fracture and associated with scaphoid bone fracture. This was a case of history of RTA, and in this case, in case of radial head fracture, we should be very aware about the entire ligament that surrounds the elbow and also got injured or damaged. This was one of the cause which was treated without any internal fixation. Here, general traction and POP was done, and it showed a good progress in healing. Going to the other another radiographic method, that is the magnetic resonance imaging MRI. Here, magnetic fields and radio frequency waves are used to detect the atoms within the body, and thus produces computer generated images. This is one such report of an MRI. This is an MRI report. The patient complains of headache only, and she came to our OPD with complaining of headache since a long time. And we tried internal medicines, but there was no result, and we started thinking of different types of headache that which mimicked the patient's complaints, like tension headache or cluster headache and all. So we asked the patient to go for an MRI, and the result was shocking because the vertebral artery was getting compressed. And we know that the vertebral artery is one of the main arteries supplying to the brain. So we do referral to a modern hospital. This is one such case where we have to do referral in order to save the patient's life. Next is the MRI of lumbosacral spine showing lytic lesions. Actually, the lytic lesions may or may not be cancerous. Lytic lesions means osteolytic lesions. It is a softened section of a bone. Getting biopsy is the best way to finalize the diagnosis. And sometimes in some of the MRI reports, we can see straightening, disc protrusion, disc desiccation, sacralization, etc. terminologies. Straightening in the sense loss of normal curvature is there. That means the straightening, and we must be careful that whether this straightening is due to degenerative disc disease, ankylosing spondylitis, or due to any growth. And disc desiccation means suggestive of degenerative changes of the disc, and it refers to the dehydration of the disc. Next is the disc protrusion. The disc present in between the two vertebral bodies tends to be displaced. The main cause for this is the wear and tear over by the time. The annulus fibrosis actually gets protruded outside. Sacralization of L5 vertebrae. This is a case MRI report showing disc bulge. Next, sacralization. Sacralization is a congenital vertebral anomaly of L5 spine. That is a fusion of L5 vertebrae within the S1 vertebra. And most people suffer with the back pain associated with it. This is an MRI showing displaced sacrum. We must be very careful in treating such cases because if we tend to give any traction or and if due to an improper traction may even damage the spinal cord. So opinions from experts should be made otherwise do referral. Next, another mode of radiographic study is the Doppler study. Doppler ultrasound imaging is used to find out the blood clots present within the blood vessels, and there's mainly two types, that is arteriography and venography. In indications of Doppler study is DVT, superficial thrombophlebitis, venous insufficiency, arteriosclerosis. This is a report of Doppler study of a patient came to our OPD with a dilated, elongated tortuous vein, that is varicose vein. And we have given internal medications and advised for some mild exercise also. But we didn't find any much result over a period. So we sent her for Doppler study. That is a venography study, and the report revealed that the SFJ, that is the phenofemoral junction, is incompetent. And if the SFJ is incompetent, then the chances, that is less than 50% of chances, therefore complete cure of the case. And this is another Doppler study report showing SFJ incompetence and also associated with the perforator incompetence. Next is the USG, another radiographic imaging technology. That is USG is a non-invasive, safest imaging techniques. Utilizes high frequency sound waves to produce images of the body with images of inside organs present inside the body. The report showing grade 1 fatty hepatomegaly, that is very first stage of fatty liver changes, which may tend to cirrhosis of liver in later. Grade 1 is easily manageable by our system of medicine by watching LFT regularly. Next is a bilateral renal tiny calculate, that too can be cured by the our medicines. Then right duplex kidney, that is a developmental condition. In this case, we should be regularly monitoring the RFT of the patient. Any noticeable change found, then that can be referred, or suggestions from the nephrologist can be taken. Left renal cortical scarring, and it should be aware that the cortical scarring may cause filtering problems, that is protein loss through the urine may occur. And in such cases, then if we are confident enough, then we can treat. Otherwise, better opinions can be taken, or otherwise referral can be done. This is another USG showing mild fatty liver and also bilateral non-obstructing renal calculate that can be cured by our system of medicine only. Then next comes the colonoscopy. Colonoscopy is an instrument. The doctor uses an instrument to visualize inside the colon, rectum and colon through the help of a camera. And here is an colonoscopic report implying the multiple patchy erythematous lesions from cecum to rectum. This patient came to our OPD with irregular bowel habits and severe lower abdominal pain, and we suggested a colonoscopy and found that ulcerative colitis by the biopsy taken. And ulcerative colitis is very well treated by our system of medicine, that is using herbal medicines and also daily practicing of yoga. And that comes to the last slide of my presentation. And I hereby conclude by saying the image gained from the diagnostic radiology helps the doctors to gain the perspective course on the symptoms of that patient may be experiencing, and to know how well the body is adjusting to the treatment, and screen for various diseases and illness like heart diseases or cancer or even fractures. Thank you.
Archana, thank you very much. Once again, very, very clear presentation. And I have one first question for yourself. The images that you presented, they're extremely clear and valid, very, very high resolution images. What is the instrument that was used for capturing these images? Do you know?
So most of the images taken from our X-ray machine, and also some of the patients are taken from outside also.
Do you know what is the instrument you have in your college?
Sorry, sir.
No, you're not aware. Thank you. Thank you. So first of all, I want to thank both our speakers for very, very clear presentations. Thank you very much, Anilji. Very, very clear, very brief, but very sharp. You took us straight to the point without too many confusions and explanations. Thank you, Archana, for broadening the scope of the discussion today and showing us a few more examples. Now, coming to Anilji's presentation and the work being done in BHU. Anilji, I found a few things very, very exciting. One is that you are annually seeing in excess of 30,000 cases in BHU. And I don't know if many people in the world know about this, but this needs to be told to the world. And particularly under the guidance of Sahuji over many, many years, you have developed several skills in BHU, particularly Sharasutra treatment procedures. And I know that there are doctors who have come to BHU from Austria to learn these techniques, Sharasutra techniques. Maybe you have met some of these people also.
We also supply Sharasutra through modern medical colleges also.
That's right. So, you know, so this, the point, the one point I want to touch again was about the development of scaling up that procedure, showing the world, because you have so many years of experience there. You know, it's like a global resource center for, you might be the best resource in the world for doing some of these procedures. And somewhere we need to see how to make this into a center of excellence of some kind. Pandeyji is here with us, and he is also developing certain areas which are almost like a global center of excellence.
Yes,
so this is something that we, perhaps it will come up in the discussion again. Number two, thank you so much for showing us about the Deshpande technique for fistulography. Very, very, your images were very clear and we have all learned from it. And also the transrectal ultrasonography images, very, very nice, and how you are bringing together the best of contemporary techniques and technology and what Ayurveda has to offer. So very grateful for that. And I think these are my initial comments here. I just wanted to show, I will come back to showing one or two other images on the screen, but I want to just open it up for all of our participants if they have something to say. Please stay with us, Anilji, because there will be comments and questions that will come through. Archana, I have a question for you. What did you think about the presentation from Anilji in BHU? Did you have some thoughts in your mind?
Actually, I have heard a lot regarding the transrectal ultrasonography and also the MRI and all, and the MRI histogram developed, and also the development made by the Deshpande sir. But I was not knowing such in depthly. I was not knowing regarding that. So for that, I am very much thankful, sir.
Thank you. Thank you, Archana. You see why we are wanting more and more MD students to come to our webinars, because you learn so much from just being here for a few minutes whenever they can find time. There is a lot to learn. I leave it here, and perhaps we can take some questions, comments from our audience. I don't know if, thank you to Agnihotriji, also alumnus of BHU, who knows the history of these departments. Pandeyji is also here with us. Pandeyji, Pranamji. Our idea, and while we were discussing Agnihotriji, Harish ji se ek aaya ji, ek chota sa ek message. He's busy in Toronto, so he cannot join us for the thing, but he has shared a very nice very valuable, very valuable information about the programs that are now available, diploma programs that are available. And this is in response to Pavanji's comments that we must have more courses. If I just display my screen, you can see from the NCIS. Harish ji, aa gaya ji.
Sir, Professor Madanji, I've got a very small inquiry.
Please. Agnil ji,
regarding,
please.
yeah, please, thank you. I've got a very small query regarding Dr. Anil Kumar. May I be enlightened for the information that he did his graduation and post-graduation probably from BHU?
My graduation is from Muzaffarpur and post-graduation is from BHU.
That's it, because the language of BHU was speaking when you were speaking.
Thank you, sir.
The command, the masterlyhood, and all that. I found that you are referring Sahuji. It means you had been a student of our IMS.
Yes, sir.
So
Yes,
great.
he's my teacher.
Not only a Sahuji, you see here, Dr. Ajay Gupta is very much here, our professor here in state professor, and we are all persons are knowing about the fistulogram, usually cut through Chart Sutra. It was not only Professor Deshpande sir, it is Professor K.R. Sharma ji, Kaviratna Sharma ji is also the basic contribution along with Professor Alam Singh, along with Professor Deshpande sir. But it's a quite surprising and great to know that Deshpande technique has got such a wonderful clear-cut response and not getting any surgeon confused regarding the status and depth and direction of the fistula, where we were having a little bit fake situation when we were going simply for the fistulogram. So it's a great one. And when we were studying, then even the anorectal, not only the anorectal, it was the anorectal unit. And
Yes, sir.
the wife of Professor Sahuji, she herself, Medula Singh, she was
Yes,
student and
sir.
she did diploma. We are talking
Yes,
about
sir.
the 42-year back history. So she, along with so many of my friends, they were also joining the anorectal, Shishupal Singh, Gyanesha Sharma and all that. So your presentation looked like a BHU presentation. I greatly congratulate you. And whenever I would like to, I will be there in BHU. I would like to meet through Professor K.K. Pandey sir. Thank you, sir.
Definitely. Thank you, sir.
Harish ji is here with us. Yeah, Harish ji, I'm just going to share aapne jo bheja abhi. Usko, I'll just display this and perhaps you want to make a comment here. What is the special? This is from the NCISM webpage and Harish ji has just highlighted this about their
Yes, sir.
diplomas.
Diploma course is already running in BHU.
In BHU.
They all are trained under my supervision. I have 8 diploma students who are pursuing this diploma course.
So you have a intake of 8 diplomas.
Four students per year. 4 students per year.
4 students per year. Achha ji. Harish ji, shayad aapki taraf se kuch ho?
Yes, sir. Yes, sir. Sir, I have 2 questions to Dr. Anil ji. Dr. Anil ji, namaskar.
Namaste, sir.
I live in Toronto, in Canada.
Harish ji is joining us from Canada in Toronto.
Yes.
So please, Harish ji.
So I left India in 2015 and I was thinking that there is a law that we cannot practice or we cannot make reports of X-rays, CT scan, MRIs. So what is the present legal status for BMS or MD Ayurveda doctors? Can they write reports of X-rays, CT scan or MRIs?
The status is same, sir, what you left here. But as an institutional practice, we are practicing it under the umbrella of BHU. That's it.
Because, and the second is, when I was there before 2015, I was practicing Ayurveda in Delhi. And I found many Ayurvedic doctors, they were put into jail because of violation of there is a PND something like that. Yeah, act. And they were doing ultrasonography and all this. And then in the courts, they were blamed that they cannot use ultrasound and all this. So what do you think? Can we use modern technologies in diagnosis?
Actually, we should definitely use it and ask our authorities to look into it, to do something for us actually. Initially, the diploma course was recognized by CCIM, but they withdraw it. They withdraw anesthesia also, Sanghyadhan also. I don't know why, but they should regularize it. They should again give the importance of these two branches and start it again.
In
That's I
fact,
can
Harish
say.
ji, this is a very,
yes, sir.
very
Sir,
important.
in fact, yeah. In fact, sir, in West, there is a law for diagnosis also. In India, there is a law only for the use of medicines. Like allopathic doctors can use allopathic drugs, Ayurvedic doctors can use Ayurvedic drugs, homeopathic doctors can use homeopathic drugs, but there is no law for the diagnosis. Like who can diagnose, whether Ayurvedic doctors can use modern diagnosis or not, whether modern diagnostic techniques they can use or not, there is no law. But in West, there is in scope of practice, when we study that, then the only radiologist, because that is the reason I told Dr. Pavan Sharma ji that many Ayurvedic doctors could not train themselves in writing the reports for X-rays, MRI, CT scan, because law is there as far as scope of practice is there. So,
This is
but as the today's topic is very relevant, because the role of radiography is vital in Ayurveda. As the time is changing, people are demanding evidence of efficacy. This is the only tool we can prove ourselves that our medicines, our procedures, our method of treatment, they are effective. Otherwise, we cannot prove it. When I was in Delhi, I was practicing Ayurveda there. Still, I have a clinic with the name of Sushruta Ayurvedic Therapy Center, and our website is sushruta.com. And there we are treating patients of ulcerative colitis. We have a lot of patients. We have records of many thousand patients of ulcerative colitis. And as you are aware, ulcerative colitis cannot be diagnosed without the help of modern technologies. Yes. Ulcerative colitis can only be diagnosed with the help of this colonoscopy and the biopsies. Yes. Otherwise, we can't diagnose it. So this is very relevant topic, but I think we should discuss more. And today, because while going through this, I was searching on the net. This National Commission has already started. Dr. Anilji, you are already giving diploma, already teaching diploma in Chaya Vigyan or radiology. Yeah. I was surprised to know the word Chaya Vigyan.
Chaya Vigyan.
Chaya word, I think, is
stands for imaging, sir.
Imaging.
So is this word is from Samhita?
No, sir. I think I don't know whether they have taken it from Samhita or not.
Right. But
Chaya stands for the imaging and Vikran for the X-rays.
Yes.
Yes.
But this is a great idea, because I practiced in my whole life. The principle of my practice was modern diagnosis, Ayurvedic treatment. Yes. Even I was trained by my teachers. My teacher, Dr. Ajay Sharma, who was later on he became director of NIA.
NIA.
Yeah. He was my teacher in Amritsar when I graduated from there. When I was a final year student, I wrote a book I'll show you. This is the book, Comprehensive Book of Ayurvedic Medicine for General Practitioners. This was the book which is based on modern diagnosis and Ayurvedic treatment.
Yes.
At that time, I made because I practiced it like this. So I am a strong believer of integration of Ayurveda with the modern science, and we can integrate if we diagnose according to modern science and if we treat the people on the principles of Ayurveda, applying all theory of Vata, Pitta, Kapha and all the principles of Ayurveda. Thank you, sir. Thank you very much.
Thank you.
Thank you, Dr.
Thank
Madan.
you, Harishi. Thank you. You are always recommending that we must take the best of modern medicine diagnostic tools
Yes.
and use Ayurvedic Siddhant and thinking to do the treatment. And I think very, very valid point. It will come up again in our discussions. Perhaps Agnihotriji has something to say.
Yes, sir.
Please.
Dr. Anil,
Yes.
what Dr. Harish Verma was pointing out, I think that as far as the PNDT Act is concerned, it lies over the use of ultrasonography machine, especially prohibited for the detection of the sex.
Yes.
The fetus is there in the womb of the pregnant lady. It is not applicable on the X-rays, and especially the rules are there that if you are using it, you have to get itself registered and get it renewed every year by the CMO of the district hospital. At the same time, if you are not using that ultrasonography machine, or it is got some disturbance or not in order to use, you have to inform, and they will seal it and give you a certificate with the date and stamp that it is not in use. So only then you will be safe that you are not that machine or that center is not making any unlawful use for the determination from the window side. So this was the especially affected. As far as the X-ray is concerned, maybe X-ray chest or the osteology, means this fracture etc. is concerned, we are safe. And moreover, one important program is also there in all the Ayurvedic colleges, that on the recommendation of NCISM, one radiologist, one pathologist, one modern medicine doctor is always there as a visiting professor or the visiting faculty. That's why we have got say 300 machine for X-ray. We have got our films and cabinet and all that cassettes. But the reporting is done by the radiologist. So the question very important that we are not reporting, we are not authorized to report, studying and reporting. And then out of that basis of that reporting as an impression, we are supposed, or the doctor posted in the shell is supposed to teach with that film to the students. If the money is deposited by the patient, then they can take away the film with them, otherwise that will be the property of the college. So was the case with the all investigation which are carried out in our pathology lab. They are put by under the signature of the visiting pathologist. So there is no scarcity, because we are of government institute. We cannot see any awkward situation. At the same time, we cannot go for any unlawful practice. So the things are very clear. As far as the private practitioner is concerned, the situation is different. So you made, I think, very clear, and rest I supplemented that in what way the use of the these ultrasound machine, MRI and this X-rays are executed there in the government sector hospital. Thank you so much.
Thank you. नीरज शायद पवन जी की मन में एक सवाल है जी, ये पवन जी शायद आपके मन में वो, हाँ जी, प्लीज कि कोर्स डेवलप करनी है।
मेरे मन में अभी भी ये क्वेश्चन है सर।
हाँ बिल्कुल जी।
हमारे बुजुर्ग क्या करते थे? ये जो जिनका ये दाढ़ी वालों का चेहरा दिखाया था, वो दाढ़ी वाले कब जन्म लिए थे? अनिल जी या वो कौन अर्चना जी?
जीवक जी।
अरे नहीं, जीवक जी नहीं साहब, ये मॉडर्न एक्सरे के जन्मदाता। अच्छा। अभी अर्चना जी ने फोटो दिखाया था।
He discovered X-rays in 1895 and got Nobel Prize.
1895। ओके सर, 1895 से जितना चल रहा है वो तो हम लोगों ने देख लिया। मेरा मानना ये है, दो ही पॉइंट पे मेरा कंसर्न है। नंबर एक तो मॉडर्न टेक्नोलॉजी हमारे बच्चों को सिखाई जाए, वो रिपोर्ट बनाने लायक नहीं, रिपोर्ट पढ़ने लायक हो। नंबर एक, वो मॉडर्न बच्चे कितने हाउ मच रीच इज देयर बाय दोज स्टूडेंट्स और दोज एक्सपर्ट्स ऑफ आयुर्वेदा और एलोपैथी। सो why can't we search those techniques which were being used by our ancestors, forefathers? कि साहब हम एक्सरे नहीं था, लेकिन फिर भी हम पहचान लेते थे कि ये रोग है। ठीक है, आज रोग बढ़ते जा रहे हैं। There are so many various numerous new diseases but we have not changed nomenclature of them. We can say anything in Vatic, Pathic, Schleswig, Sannipathic, anything we can define. So why can't we search what were those techniques? If those techniques can be communicated to the Vaidya in the rural area, that will be the great benefit for the society. Today, just a sec. When orthopedic fails, the person goes to Jarrah. That is a quality of the orthopedic surgeon in Unani. Jarrah. In my Calcutta, bone setters are there. Bone setters. People, our society is not believing on MS orthopedics. They are going to set their bones to that Jarrah or the bone setter, and they are feeling happy. This is our situation of our country. So one time we are talking about a high-end technology like sonography, this and MSCT, whatever it may be. And we are knowing that very much fact that our Indian population is not allowed to access that technology in 80% of the area. So what will be the future of 80% area without X-ray? Without X-ray. So whether we should promote those Jarrah bone setters or we should go for this high-end technology which is not possible at rural areas. This is only my frustration or question, whatever you can say. Thank you, sir.
Thank you, Pavanji. Thank you. Very important point. Everybody on this platform will recollect Anil Johri ji from Quality Control India and his initiative to develop a certification scheme for village Vaidyas, Gram Vaidya certification.
Traditional health practitioners.
हाँ जी. So I don't know, शायद Pavanji, शायद आपके मन में उस तरह की सोच.
Yes, sir. QCI will be going to identify them as traditional health practitioner, and they will be allowed for treatment of their respected area, particular respected area. So why can't we take this movement as a broad, and BHU persons or expert persons will teach the rural villager doctors, Vaidyas and quack doctors that please treat like this, please read like this without X-ray. For that, we have to understand first that our forefathers, our great Maharshis, how they were understanding that this is fracture or crack. They were only treating with the bamboo sticks and they were just bandaging it and they all fracture. And then the same way bone setters are doing at present in this 2020. Why can't we? When bone setter, a unskilled person, unliterated person who is not knowing the anatomy and physiology of the body, who is setting the bone, what does it mean of a MS orthopedic when he can't be available on 80% of the rural area? Thank you, sir. Thank you.
Thank you, Pavanji. Thank you for, I think what you are asking us is a balanced approach. Don't forget what the bulk of the country needs and see if we can get the best of the thinking from the advanced institutions and bring a marriage between these two systems. Thank you, Ji. Thank you. I don't know, हमारे साथ पांडे जी है. पांडे जी, आपके thank you so much, Kuldeep ji, Pandey ji, for introducing Dr. Anil to our platform today. And we can see from Anil ji's presentation the precision and the very ease with which he takes us into the heart of the matter. Perhaps that is part of the BHU training, as Agnihotri ji says. So we are grateful. I hope in the months to come, you will introduce many more people like Anil ji from BHU to our platform so that we can all learn from the style and the quality of the presentations. That is a trademark, hallmark of BHU. And we need more people to learn about this. With how simplicity and clarity, Anil ji, you have taken us into with a few images, just one or two images, You have taken us into the heart of the matter. And you didn't go into any of the other details, but straight to the heart of the matter. So same thing with Pandeyji. We learn every time he's here with us, and he teaches us a lot. Pandeyji, namaskar ji.
Pandeyji, pranam. In the
Pandeyji is
meantime, I would like to inform you regarding tomorrow's webinar, sir.
Hanji.
First webinar is from 6:30, Uttarakhand Day, Uttarakhand
Yes.
Parampara, initiated by Dr. Vineet Kumar Agnihotri ji. I am really grateful to him. All senior dignitaries from Uttarakhand of Ayurveda will join us for Uttarakhand Vaidya Parampara tomorrow at 6:30 p.m. As we were finalized one webinar before this, so that is also very important issue. Legal Services Day is there tomorrow. So Ayush Essential Legal Issues, where Dr. D.C. Katoj will be there, Dr. Ashutosh Gupta from NCISM will be there, Dr. Bhavdev Ganatra, Guinea Book World Record holder will be there, Dr. Deepti Balakrishnan, Professor and HOD Chennai Urti, Dr. Soren Chaudhary, legal expert, Dr. Himanshu Tiwari. It will be from 7:30. The link will be same and the YouTube link will be different for both the webinars. And we are eager to celebrate these both webinars tomorrow and on 14th also. Just for your sake of your information, on 14th Children Day is there. On 20 Universal Children Day is there. One is national, one is universal. I am really grateful to the universal persons that they are celebrating every day by 10 or 20 names. I am confused that what can be related with the AYUSH. So on 14th itself, because we are celebrating Children Day on 14th only, we have conducted two webinars, one for National Children Day, the Children Day, Diabetes Day, both are there. So we have selected our topic, the AYUSH for diabetic children. Diabetes is also there, children is also there. And for second webinar, as Universal Children Day is there, AYUSH for holistic development of children. These two webinars tomorrow and on 14th, these will be conducted. Kindly support, sir. This platform is yours. Please continue. Sorry for interruption.
Thank you, Pawanji. Thank you for showing us what we will be experiencing and sharing with everybody tomorrow. On first, a few screen shares here, Pawanji. Ek to pehla, this is the format of that certificate, the voluntary certification scheme for traditional community healthcare providers. You can see it is a joint initiative between Foundation, FRLHT, Foundation for Revitalization of Local Health Tradition and Quality Control India. Anil Johri ji was very deeply involved in this. And you can see the format of this certificate. That it says the individual, whether it's a bone setter or whatever, a community midwife or whatever it is, has been evaluated and certified as a traditional community healthcare provider, as per the criteria prescribed under the voluntary certification scheme for traditional community healthcare providers. And then the language of the examination is indicated and the validity of the certificate too is indicated. And this, I'm happy to say, comes from a Center for Trade Testing and Certification of Skilled Workers in the south of India, in Kerala. Their website is shown here, worldwideweb.cttcnab.in. Now, I share this because Anil Johri ji has been with us on many discussions before, and he's very dear to us in the kind of way in which he is pushing for standards and other issues. And also, Agnihotri ji has in several discussions, he has emphasized, using Uttarakhand as an example, the difficulty of getting healthcare to the rural community. And we need to encourage what Pavanji has just highlighted. We need to encourage the growth of this excellence and the best of knowledge that comes from institutions like BHU, IMS, or our All India Institutes, including one now in Uttarakhand. There is All India Institute Medical Science there. But don't forget the rural community. Don't forget the masses who are there. Perhaps Agnihotriji has something to say. And after Agnihotriji's comments, I just want to show one or two images. Another area where imaging becomes very important, and it's about ischemic stroke. And within that area of ischemic stroke, I want to see if I can connect two possibilities. Ayurvedic intervention for ischemic stroke, for recovery from ischemic stroke. Number two, I want to highlight that one artery and the way we get diversity in individuals for one artery of Pecheron, it is called, and how it becomes almost impossible to understand the nature of that ischemic stroke unless you have a good image. So Agnihotriji, the point about rural community that Pavanji just raised, and I think Pavanji is saying, let us bring all these resources together so that the highest quality from the established institutions can be connected with what the community needs in the villages. And perhaps you have something to say, because in many comments before, in many of our discussions before, you have told the difficulty in the rural areas.
Sir, thank you so much. Very rightly, you raised this point that all sort of facilities, medical facilities are also supposed to be available to the outreached persons living. And in reference to the Uttarakhand, it's not only the rural area, it's the, say, hill area, the Durgam area, where the lady doctors are not there. So that's why the male doctors are supposed to perform the deliveries, and even X-rays are not there. We do remember 1991 earthquake in Uttarkashi. There a number of patients were there, and we were sent as a relief team. And we, by all means, made helicopters available to airdrop the such suffering patients. A lady who was suffering, a lady who was pregnant, almost 7th, 8th month, and got fractured, femur fracture. She was airlifted and sent to Uttarkashi hospital. So these are the area where we see the border area district, Uttarkashi, Champavat, this Pithoragarh. These are the area where modern medicine follows are not much more, irrespective of the claims that they are there, district hospitals are there. But in the remotest area, they got appointment, and after 3-4 years wait, the Public Service Commission withdraws their posting simply because they have not joined. So there is the role of our Ayurvedic doctors, which we are going to say something on tomorrow. But at the same time, which Dr. Pawan Sharma ji told that in Calcutta, not only in Calcutta, in every district of state of our India, such type of jarras were there way back 50 years or so, and they were not only fixing the fractured bones. If they were not qualified, they were not given any education there, they were not having any certificate or degree, but they were having the experiences under the skilled persons off and on. So they were 60, and not only, they were also going for cupping, the singi lagao, singi, the taking out the impure blood from the wounds and from such things. It was a very important, and it was in practice in our area that singi lagwa lo. Those who are the dushtravan ka upchar singi se wo log karte the, they were known the jarrat. I think that community coming from the saloon or the barbers group, ultimately they simply limited their activities only to for the saloons. So our submission is that Ayurvedic BMS, Ayurvedic MD doctors and Ayurvedic government doctors, they are performing a lot, especially in Uttarakhand, and I think so is the case in the remotest areas of our Uttar Pradesh and whole of the country. So our tools are very important, but where they are not, the presence of mind, the experience, the taking knowledge from the very skilled gurus, like our Professor Bimanand Parasharji. He was expert as far as the this astrology and this fracture is concerned. Always, sometimes the cases reached to AIMS Delhi, and his name was so popular that when the patient's attendant told that I am coming from Haridwar, the doctor's orthopedic surgeon told that if you are coming from Haridwar, have you not consulted Dr. Parasharji? Your treatment was there. So this was the skillness of our, and he was the simply apart from BMS Rishikul, he was this HPA from Jamnagar, and he with the subject Panchkarma, but he involved himself completely on the orthopedic surgery, and great name. All the Gujar coming from the top of the hills, they were bringing their patients on cot, 3-4 attendants with them, and they were getting the treatment. So our submission is this much, that as per the need and as per the situation, we are supposed to manage ourselves so that the suffering humanity must get the relief. This is what my assumption. Thank you, sir.
Thank you. Agnyodriji, thank you for giving us so many details every time. Also, this situation will be similar in many districts of Himachal Pradesh too. What is seen in Uttarakhand will also be the demands and the needs will be similar in many areas of Himachal, also the mountainous areas of Himachal. Agnyodriji, the reason why I'm trying to make this connection between the theme of today's webinar and the need for imaging techniques, and particularly going into other areas, brain trauma in the kind of ischemic strokes, for instance, is just to show whether there are opportunities for developing some collaborations between our understanding in Ayurveda, particularly Basti as a technique, and use of Basti as a technique for helping with certain neurological conditions, particularly ischemic stroke, and how there might be an opportunity to bring all of us together. And in Toronto, where Harish Ji is, he's already discussing many things with the university health networks in Toronto, big network. I think Harish Ji says it's the 3rd largest hospital network in the world. I think Harish Ji agrees with me. And there is a brain center there, the Krimble Center, and Harish Ji and his team are working there. People like Pandeyji and yourself in India. And from our interactions on Ayurveda Day in Berlin, there is a big German stroke research center there in Berlin. And how it is today possible to at least raise those points about a future collaboration between Europe, India, and North America, for instance. It's just an example. And the theme that we have touched on today of imaging as an important area, but using Ayurvedic interventions like Basti and Nasya, for instance. Harish Ji, आपसे भी तो सुनने दीजिए अगर हमारी सोच सही है कि नहीं.
बिल्कुल ठीक है सर. सर मेरा एक सजेशन है, बिकॉज इस प्लेटफॉर्म के जरिए हम अपनी आवाज गवर्नमेंट तक पहुंचा सकते हैं. ये जो एक नया कॉन्सेप्ट आपने अभी एक सर्टिफिकेट शो किया है कि रूरल एरिया में आयुर्वेदिक जो प्रैक्टिशनर्स हैं उसकी रिक्वायरमेंट भी है, बिकॉज द पॉपुलेशन ऑफ आवर कंट्री इज वेरी हाई. तो हमें डॉक्टर्स प्रैक्टिशनर्स भी चाहिए, बट हमें मेरे ख्याल टाइम आ गया है, नाउ द टाइम हैज कम कि गवर्नमेंट शुड डिसाइड द स्कोप ऑफ प्रैक्टिस ऑफ प्रैक्टिशनर्स. अब जो रूरल एरिया में प्रैक्टिशनर काम करेगा, अगर तो हम उसका स्कोप ऑफ प्रैक्टिस एक लिमिट कर दें कि भाई आपने खांसी, जुकाम, नजला, छोटी छोटी बीमारियां, डायरिया, डायसेंट्री, इस तरह की हिस्ट्री लेके ये दवाइयां इस्तेमाल करनी है और इससे आगे यू हैव टू रेफर, वो करना पड़ेगा. अदरवाइज बहुत, अगर जैसे पवन जी ने कहा, अब वी कांट कंपेयर जरा विद ऑर्थोपेडिक सर्जन. ऑर्थोपेडिक सर्जन का अपना रोल है, जरा का अपना रोल है. ये भी वो जरा जो काम कर रहे हैं रूरल एरिया में, ठीक है, वो भी उनका सक्सेस रेट हो सकता है अच्छा हो, बट हम ऑन द अदर साइड जो क्वालिफाइड लोग हैं उनको भी इग्नोर नहीं कर सकते, एक सिस्टम है। तो नाउ द टाइम हैज कम कि हमें एक स्कोप ऑफ प्रैक्टिस डिसाइड करना चाहिए कि जो रूरल एरिया में काम कर रहे हैं लोग वो अपना डायग्नोसिस आयुर्वेदिक नाड़ी परीक्षा से करें, जो आयुर्वेद का विधान है। उससे आगे अगर वो यूनिवर्सिटी में लोग पढ़ रहे हैं, यूनिवर्सिटी कॉलेजेस में पढ़ रहे हैं, बीएमएस एमडी पीएचडी कर रहे हैं आयुर्वेदा की, उनका स्कोप ऑफ प्रैक्टिस अलग होना चाहिए। उसमें हम लोग ये मॉडर्न इमेजिंग, मॉडर्न डायग्नोसिस, मॉडर्न रेडियोलॉजी ये सब डाल सकते हैं, मॉडर्न लेबोरेटरी टेस्ट। अदरवाइज तो कोर्ट्स में जाके बड़ी कंफ्यूजन हो जाएगी। एक अभी जो पीछे होता आ रहा है कि क्योंकि जो मैं उस केस में हम लोग काफी इंटरेस्ट रखते थे जब मैं व्हेन आई वाज इन इंडिया, जो एक एलोपैथिक आयुर्वेदा का एक फाइट चल रही थी कोर्ट में, पंजाब से था वो आदमी जिसको वहां के ड्रग इंस्पेक्टर ने एलोपैथी यूज कर रहा था वो व्यक्ति, उसको ड्रग इंस्पेक्टर ने कहा कि यू कैन नॉट यूज इट एज पर लॉ। वो 28 ईयर्स तक वो कोर्ट में केस चला, सुप्रीम कोर्ट में। उसमें हम लोग बहुत इंटरेस्ट ले रहे थे, कमेटीज में और सब में आना जाना था। देन आई रियलाइज्ड कि तो उस एंगल से मैं सोच रहा हूं कि अब टाइम आ गया है कि हमें डिसाइड करना चाहिए, गवर्नमेंट को डिसाइड करना चाहिए कि रूरल एरिया में जो लोग प्रैक्टिस करेंगे उनका स्कोप ऑफ प्रैक्टिस क्या है। अदरवाइज कोर्ट्स में जजेस के सामने अगर हम आज का एज ऑन टुडे इफ वी लुक एट द राइट्स ऑफ अनक्वालिफाइड रजिस्टर्ड मेडिकल प्रैक्टिशनर एंड BMS, MD, PhD in Ayurveda, तो लीगल राइट सेम है एज ऑन टुडे। अब जज के सामने बड़ी प्रॉब्लम है। वहां जजेस के सामने जाके हम जब बोलते हैं कि जी हमारी किताबों में ये लिखा है, हमें पढ़ाया जाता है, वो इसलिए पढ़ाया जाता है, जज के सामने RMP डॉक्टर भी है, लॉ सेम है, स्कोप ऑफ प्रैक्टिस निर्धारित नहीं है। तो देयर इज ए कंफ्यूजन। नाउ द टाइम हैज कम, हमें इसकी डिमार्केशन करनी चाहिए। जैसे ये देखिए, मैं आपसे एक स्क्रीन शेयर करता हूं। कनाडा में यहाँ पर नेचुरोपैथ्स होते हैं, ये कॉलेज ऑफ नेचुरोपैथी इन ओंटारियो है। इनका स्टैंडर्ड स्कोप ऑफ प्रैक्टिस, तो इन्होंने हर चीज डिफाइन कर रखी है कि आपके कोड ऑफ एथिक्स क्या है, प्रोफेशनल पॉलिसीज, एडवर्टाइजिंग गाइडलाइंस भी, कितना एडवर्टाइज कर सकते हैं। अब हमारे आप अखबारों को देखिए, कई लोगों को आयुर्वेदा की प्रैक्टिस करते हैं, उनको पता ही नहीं है एडवर्टाइज कैसे करना है। अपने आप को लिखते हैं यूरिन स्पेशलिस्ट, सेक्स स्पेशलिस्ट, ये क्या है? तो इसको ये गाइडलाइंस है इसकी स्कोप ऑफ प्रैक्टिस में। तो असाइनमेंट ऑफ केयर गाइडलाइंस, कॉन्फ्लिक्ट ऑफ इंटरेस्ट गाइडलाइंस, कोर कॉम्पिटेंसी गाइडलाइंस, contraindications of manipulation, guidelines COVID reopening, guidelines non-medical cannabis, जो cannabis यहाँ बहुत यूज हो रहा है, इसके बारे में guidelines है, referral consultation, informed consent guidelines, managing risk in clinical practice guidelines, mandatory reporting guidelines। ये सारा कुछ हमें, ये सारा कुछ हमें
इसके डॉक्टर साहब, इसमें ये जो लिंक आपने उसको, कैन यू शेयर इट ऑन आवर चैट बॉक्स डॉक्टर साहब?
yes.
इसमें आई कैन सी Pandey ji is here, and I think Pandey ji is reflecting on wanting to share something with us. Pranam ji.
जी sir. I'll share in the
Pandey ji, ये जो हरीश जी का पॉइंट, इसके ऊपर शायद आपके मन में कुछ होगा जी, ये स्कोप ऑफ प्रैक्टिस और ये जो डिटेल्ड, इतनी डिटेल में दे रखा है जी, many aspects. Is it something we should implement in India? Whether we should, it should be implemented, but how quickly? What is the correct procedure? Should it be? It must be a central government initiative or something.
सबको प्रणाम।
नमस्कार, प्रणाम जी, प्रणाम।
इस पे मैं थोड़ा बाद में आता हूँ। पहले तो मैं दोनों स्पीकर्स को बहुत बहुत साधुवाद देता हूँ कि बहुत ही शॉर्ट नोटिस पे डॉक्टर अनिल को मैंने कल बोला मॉर्निंग में, और बड़ा हेजिटेट कर रहे थे, सर हाउ आई विल प्रेजेंट, आई हैव नो आइडिया टू प्रेजेंट एनीथिंग। देन आई सेड you just come and say like that you teach in your class.
So,
Actually, related to topic, there are 2-3 points I would like to share. First, what is the importance of this one? Because after importance, only we can say that that should be taught to the students. While teaching my students, I use to say that इंसान को 2 आंख होता है, शंकर जी को 3 आंख होता है, और डॉक्टर को 4 आईज होती हैं. First one, just to inspect, then interrogate, then make investigations, then last you go for impressions. And after that, you need investigations, and there are many more areas where we need imaging. And this imaging is not only required for the proper treatment, but for further treatment modalities, and make an evidence that this was the of that patient, and on that very basis, we have moderated the line of treatment accordingly, and that was the positive result for the health of the patient. प्रॉब्लम कहाँ है? हमारे यहाँ अंडर ग्रेजुएट के स्टूडेंट जो मेरे पास आते हैं इंटर्नशिप में, वो बिल्कुल ही इमेजिंग नहीं जानते हैं. नॉट ओनली दिस, जब मैं मॉडर्न मेडिकल साइंस की फैकल्टी में अपनी टीचिंग ट्रेनिंग ले रहा था, उस समय भी एमबीबीएस के स्टूडेंट्स आते थे, उनको भी इमेजिंग नहीं आती थी. आज क्या है कि पीजी एंट्रेंस में जो टॉप मोस्ट होता है वो मॉडर्न मेडिकल साइंस में रेडियोलॉजी प्रेफर करता है. बट हमारे यहाँ शल्य का या निदान का या काय चिकित्सा का कोई भी स्टूडेंट नहीं चाहता है कि वो इमेजिंग में जाए और ट्रेनिंग ले या अपनी स्पेशलिटी को डेवलप करे. वो सोचता है मैं तो एक कंपाउंडर हूँ. जैसे पहले एक टाइम था एनेस्थीसिया की टॉप मोस्ट सीट लेते थे, जैसे हम लोग ऑल इंडिया सेलेक्ट में टॉप मोस्ट सीट लेते थे कि हमको संज्ञाहरण लेना है. आज जो गवर्नमेंट की पॉलिसीज हैं, I don't want to comment and criticize the policy makers, but they are ignoring the basic need of the health system. 80% population, हम रेगुलर बोलते रहते हैं, हर फोरम पे बोलते हैं, हर स्कॉलर बोलता है कि there is a need of scholars trained and skilled. अब स्किल्ड आज जब आती है तो देयर आर मेनी सिचुएशन. आप देख रहे हैं कि आज जो है ट्रॉमा बढ़ते जा रहे हैं, ट्रॉमा के इंसिडेंट्स बहुत बढ़ रहे हैं. अब उसमें सबसे बड़ी चीज होती है जब हेड एंड नेक फ्रैक्चर होता है या लॉन्ग लिम्स में होता है, तो उसमें हमको पेशेंट को कैसे रखना चाहिए कि फर्दर ट्रॉमा नहीं हो. ये नहीं कि हमने उसको लपेटा बांधा और लेके चले गए टर्शियरी और प्राइमरी सेक्टर. नहीं सर, आपको इतनी बेसिक इंफॉर्मेशन होनी चाहिए कि अगर ऐसे ट्रॉमेटाइज होगा तो इतना कंसील्ड ब्लीडिंग होगा, उसके क्लिनिकल पिक्चर ऐसे मिलेंगे, और उसमें हमें पेशेंट को ट्रांसपोर्टेशन के समय ये ध्यान रखना है, अदरवाइज सर्वाइकल फ्रैक्चर में ले जाते तो पेशेंट मर जाएगा. दूसरी बात है कि जब बहुत सारी ऐसी कंडीशन, इवन जैसे अभी कोविड की बात करते हैं हम, तो कोविड में जो प्रॉब्लम्स आई और इम्प्रूवमेंट जो हुए लंग शैडोज के, वो हमारी आयुर्वेदिक ड्रग से कितनी इम्प्रूव्ड हुई, ये भी हमें एक एविडेंस शो करता है. ऐसे ही नहीं कि हमने कर दिया, ठीक है पेशेंट को ट्रीटमेंट दिया, पेशेंट हो गया, लेकिन आपके पास सबूत क्या है? आप एविडेंस दोगे ना. सीटी स्कैनिंग हो रही थी कि चलो लंग कंसोलिडेशन हो गया, ये हो गया. बीइंग एन एनेस्थेटिस्ट, मेनी टाइम्स वी रिक्वायर दिस रेडियो डायग्नोसिस. कभी हमें उसको नेक देखना होता है, कभी हमको स्पाइन देखनी होती है, कभी उसके अदर बॉडी ऑर्गन्स देखने होते हैं, सॉफ्ट टिश्यूज देखने होते हैं. ऊपर चलते हैं तो पैलिएटिव केयर में मैं पेट स्कैन देखता हूँ कि इसकी मेटास्टेसिस कैसे हुई। अभी कल भी मैं बात कर रहा था कि हम अपने ऐसे कौन से पैरामीटर्स डेवलप करें आयुर्वेद में कि हमें पता हो जाए कि हम किस टाइप के कैंसर को ट्रीट करने। अभी मैं एक वेबिनार के कुछ सुन रहा था, थोड़ा सा उसके क्लिप्स, तो उन्होंने ये कहा कि सुश्रुत के जो षड्विध क्रिया काल है उसमें हम कैंसर लाइक डिजीज को कोरिलेट कर सकते हैं। दैट्स वेरी नाइस एंड दिस वाज द ओनली कॉन्सेप्ट ऑफ द सुश्रुत। और जहां तक हिस्ट्री में आप जाते हैं तो बहुत पहले एक रिटायर्ड जज कहीं मुझे पार्टी में मिले तो उन्होंने कहा, डॉक्टर साहब आपके यहाँ रेडियोलॉजी में छाया विकिरण में डिप्लोमा आप देते हैं, इसके पहले की हिस्ट्री आपको पता है? मैंने कहा नहीं सर। बोले तक्षशिला में एक स्टोरी है कि तक्षशिला में वहां पर कुछ लकड़हारे लकड़ी काट के ले जा रहे थे और जो मुगल के या अंग्रेज के टाइम के लोग थे उन्होंने देखा कि उस लकड़ी के आर पार दिख रहा है। उन्होंने उस लकड़ी को चुरा लिया और उसके बाद ले गए। तो बाद में भोज प्रबंध में भी मिलता है रेफरेंस की भूत प्रसादन मणि हुआ करती थी जो एक्सरे का काम करती थी, जो राजवैद्यों के पास हुआ करती थी। लेकिन ये तो इतिहास की बातें है ना सर, यहाँ तो कोई एविडेंस है नहीं। अब नाड़ी की बात अभी बीच में कही गई कि नाड़ी से हम उसको कोरिलेट करें। आप बता दीजिए कितने ऐसे नाड़ी वैद्य हैं जो अपने ज्ञान को स्टूडेंट्स में बांटना चाहते हैं या नाड़ी देख के वो डिजीज बता देते हो। अंदाज मारना दूसरी बात है, लेकिन हमें इंटरनेशनल साइंटिफिक फोरम पे खड़े होके अपनी बात को साइंटिफिक लैंग्वेज में प्रूव करना पड़ेगा। अगर स्टैब्लिश होना है, किसी चीज को स्टैब्लिश करना है तो हमें एविडेंस चाहिए। और वैसे ही बहुत सारी चीजें हैं जो हमारे स्टूडेंट को, गायनी की प्रैक्टिस है उसमें आपको पता होनी चाहिए। जैसे डॉक्टर अनिल ने कहा कि सुश्रुत को उस समय पता था कि मूड गर्भ की जो खील प्रतिकूल और जो सब स्थितियां हैं ये कैसे पता हुई कि उनका हाथ होगा पांव ऐसे होगा। दूसरा जो है काय चिकित्सा में आई, इमरजेंसीज में आई, अस्थमेटिकस में आई है, एपिलेप्टिकस में आई है, एक्लेम्सिया में, बहुत बच्चों में आई है। टॉफ देखना है, हमें कैसे पता करेंगे आप? अगर इमेजिंग नहीं है तो आप एक भी पेशेंट अगर अपने ट्रीटमेंट में लूज करते हो तो ये हो सकता है कि आप 1000 पेशेंट में एक पेशेंट लूज कर रहे हो, दैट इज 0.01%। बट जिस फैमिली का एक भी बच्चा, एक भी मेंबर जाता है, he has lost 100%। तो हमें उस 100% को दिमाग में रख के लाइन ऑफ ट्रीटमेंट डायग्नोसिस बनानी है और इसलिए जरूरी है रेडियो। और जहां तक अभी अग्निहोत्री सर ने बताया कि कुछ एक कॉलेजेस में एक्सरेज की रखी गई है, क्षार सूत्र में 80% लोग जो है क्षार सूत्र से ट्रीट होते हैं। आयुर्वेद की पहचान क्षार सूत्र से हुई है, ठीक है। उसके लिए मिनिमम एक्सपेंसिव और जो डिवाइस देशपांडे सर की थी उसको हम लोग एडॉप्ट कर सकते हैं और उसको पॉपुलराइज कर सकते हैं। कुछ तो करो, शुरुआत तो करो कहीं से। पवन सर ने कहा कि हर एक कॉलेज में इस तरह से शॉर्ट टर्म कोर्सेज होते हैं। मैंने कई बार अपील किया और ये क्रेडिट जाता है हमारे कलीग डॉक्टर डी एन पांडे जी को, जिन्होंने लड़ भिड़ के छाया विकिरण कोर्स को यहाँ पे डिप्लोमा शुरू कराया अपने रिसिंग में। और आज जरूरत है कि हर एक आयुर्वेदिक इंस्टीट्यूशंस में, एटलीस्ट हमारी कंट्री के स्टेट वाइज ले लीजिए, जो जिस स्टेट में है वहां पर जो कॉलेजेस हैं उसमें कुछ एक सेमिनार वर्कशॉप 3 days का ही रखे, नीड बेस्ड एजुकेशन इन रेडियोलॉजी। मैं समझता हूँ लोगों में इंटरेस्ट क्रिएट होगा। पहले आपको इंटरेस्ट क्रिएट करना होगा, वो अपनी अच्छाइयां बतानी होगी, अपनी जादूगरी दिखानी होगी, देन ओनली यू कैन हिप्नोटाइज एंड मेक देम योर ओन। आप जब तक उसके लिए आपको थोड़ी एफर्ट करनी होगी, मेहनत करनी होगी और हर एक डिसिप्लिन के लोगों को जो लेटेस्ट टूल्स टेक्नोलॉजी है उसको अडॉप्ट करना होगा। अभी एनसीआईएसएम के अथॉरिटीज से मेरी 3-4 बार बात हुई, उन्होंने कहा कि देयर इज नो हेजिटेशन टू यूज टूल्स एंड टेक्नोलॉजी ऑफ मॉडर्न साइंस, और इसको हमें यूज करने से कोई रोक नहीं सकता है। जहां तक पीएनडीटी एक्ट की बात आती है वो दूसरी चीज हो जाती है, वो उनके ऊपर भी लागू है, हमारे ऊपर भी लागू है, ऐसा नहीं है। लेकिन टेक्नोलॉजी को जानने के लिए, प्रयोग करने के लिए हमें उसको नॉलेज होना चाहिए। सरप्राइजिंगली हमारा कोई भी स्कॉलर वह उसको ऑब्टेन नहीं कर रहा है रेडियोलॉजी को, जबकि वो उसको समझता है कि मैं कर लूंगा तो मुझे लोग 2nd ग्रेड सिटीजन समझेंगे, हमें कंपाउंडर समझेंगे। जैसे आज लोग कहते हैं अरे एनेस्थीसिया नहीं है तो क्या हम लोकल में कर लें। इतना कर लोगे लोकल में? कौन से पेशेंट को कर लोगे? क्या बच्चों को कर लोगे? जिनको पेन ज्यादा होता है उनको कर लोगे? जो शॉक में उसको रिस्टोर कर लोगे? जो पेशेंट गैस्पिंग में उसको इंट्यूबेट करके वेंटिलेट कर लोगे? नहीं पॉसिबल है। तो आपको इन टोटल सबकी इंपॉर्टेंस को समझ के एक साथ बात करनी है। जहां तक अभी आपने पूछा कि बहुत सारे लीगल इश्यूज हैं, हमारी कंट्री के लिए क्या क्या कर सकते हैं, सर इसमें हम लोगों का बोलना उतना ज्यादा मायने इसलिए नहीं रखेगा कि दीज आर द गवर्नमेंट पॉलिसी। वो हमें रिस्ट्रिक्ट कर देते हैं जो इंस्टीट्यूशनली टॉट एंड ट्रेन्ड हैं, उनको इवन इंस्टीट्यूशंस में और मेट्रोज में भी काम करने से मना करते हैं। देन व्हाट टू थिंक अबाउट द रूरल प्रैक्टिसेस? तो जब तक गवर्नमेंट इस बात को, प्रॉब्लम कहाँ है सर? जो पॉलिसी मेकर्स हैं उनमें से आप देख लीजिए, आई सॉरी टू से कि उसमें बहुत सारे ऐसे लोग हैं जिनको किसी भी इंस्टीट्यूशन के लोगों से आगे हाथ बढ़ा के बात करना, पॉलिसी बनाना और प्रोस एंड कॉन्स को देखना कि जरूरत क्या है, फ्लॉज कहाँ है, मॉडरेशन कहाँ कर सकते हैं, फिजिबिलिटी कितनी है, इकोनॉमी कितनी एक्सपेंडिचर होगी, यूनिट कैसे डेवलप करेंगे और उसकी फंक्शनिंग और फीडबैक कैसे लेंगे और फिर फर्दर डेवलप कैसे करेंगे, इसकी बड़ी शॉर्टेज है और इस विजन की शॉर्टेज है। इसके लिए तो पॉलिसी मेकर्स और गवर्नमेंट ही सोच सकती है कि व्हाट वी कैन डू, what are our limitations. Our limitations is only that one, what I observed during my career of 33 years, that our limitations, our rights are in the hands of the policy makers. वो जो बोलेंगे वो हम करेंगे। जब वो बोलेंगे, एक कमेटी आई उसने एनेस्थीसिया शुरू कर दिया, दूसरी आई उसने कहा नहीं बंद करो, एलोपैथिक ड्रग यूज करते हैं, आप आयुर्वेदिक बेहोशी वाली दवा दे दो। ठीक है, हम आयुर्वेद की बेहोशी की दवा नहीं दे सकते हैं क्योंकि हमारी मैन्युफैक्चरिंग रसायन द्रव्य गुण में आज तक बना के दिया नहीं। मॉडर्न मेडिकल साइंस में वो लोग बनाते हैं, एक एक नई नई दवाएं देते हैं फार्माकोलॉजी ने। लेकिन आप हमें ये बताओ कि सर्जरी की प्रैक्टिस करते हो, 58 सर्जिकल प्रोसीजर्स आपने गवर्नमेंट गजट नोटिफाइड किया है, उसमें क्या एलोपैथिक ड्रग्स नहीं यूज होंगी? सब ओरल ही चलेंगी या चूरन चटनी ही खिला के हम उनको जो है ऑपरेशन कर लेंगे, पेन खत्म कर देंगे, जिनको मुंह से पानी भी नहीं दे सकते? नियोनेटल्स में आप पैदा होते ही बच्चे को बिना ड्रिप लगाए, बिना एंटीबायोटिक्स, बिना लाइफ सेविंग ड्रग के रेस्क्यू कैसे करेंगे? एसबीए के पेशेंट को सिजेरियन या डिलीवरी कराने जा रहे हैं, आप क्या ट्रीटमेंट देंगे? या क्या गायनी वालों ने ढूंढा है? क्या ये चिकित्सा वालों ने एस्थेटिस, एपिलेप्टिकस और स्टर्मेटिकस और शॉक के पेशेंट को ढूंढा है? So these are the things where they are deserving. They can only make their policies. They can only restrict you that this is your limitation. This one you can do. I'm very sorry to say these bitter words, but they have to think about the total development of Ayurvedic education and need of the country like our. So integration is the very foremost requirement for the overall development of the nation, not only Ayurveda or Ayush. Integration is the need, and that was the great vision of Mahamana Pandit Madan Mohan Malviya ji, who has established world topmost university at BHU in our country. And that was the vision: integration, integration, and integration, and institutionally taught and trained with the latest modern technology, with the utilization of the ancient wisdom. We are lacking here, sir. And that should be. Unless it is not there, we will not be succeed anywhere. आज रीजन क्या है कि हम पूरे विश्व में पिछड़ते चले जा रहे हैं, वो लोग आगे चले जाते हैं, हमारी आयुर्वेदिक ड्रग को पेटेंट करा लेते हैं, हम लोग पीछे रह जाते हैं, हमें रिस्ट्रिक्ट कर देते हैं कि नहीं आप कुछ नहीं कर सकते हो। अगर मैं आज चाहूं कि मैं कैंसर ड्रग डिजाइन डेवलपमेंट में आगे बढ़ रहा हूं, मुझे इंस्ट्रूमेंट्स चाहिए, मुझे राइट्स चाहिए, तो हमें कुछ नहीं मिलना। क्या ले सकते हैं आप बताइए? किसके साथ कोलैबोरेट कर सकते हैं? नहीं कर सकते हैं। आपके पास एमओयू नहीं है क्योंकि आप अथॉरिटीज से बंधे हैं, उसमें कमेटी के मेंबर्स वो हैं जो आपको टर्न डाउन कर देंगे, आप नहीं जा सकते हो आगे, आपको अपने बेस पे करना हो। फिर हम सोचते हैं चलो हमारा नाड़ी विद्या अच्छा था, हम नाड़ी पकड़ गए। कितने लोग हैं नाड़ी प्याले? कितने आपको नाड़ी विज्ञान समझाएंगे? हम त्रिदोष की बात करते हैं, इंटरनेशनली वो कहते हैं आप स्टैब्लिश करो। वात पित्त कफ क्या है? हमारे बीएचयू में 2 स्कूल्स हैं थॉट्स के, एक कहता है वात भारी होता है, दूसरा कहता है कफ हल्का होता है। तो कम से कम अपने त्रिदोष सिद्धांत को स्टैब्लिश करो। मैंने तो आज तक कोई बुक नहीं पढ़ी सर कि जिन्होंने आयुर्वेदिक प्रिंसिपल्स में फिजिक्स की लैब है, मैथ्स की लैब है, हमारे यहाँ शरीर की या रचना शरीर की कोई लैब ही नहीं है जिसमें एस्टेब्लिश किया जाए कि त्रिदोष सिद्धांत में ये पैरामीटर्स होते हैं और उनकी ये जो है बायोलॉजिकल स्टेटस होती है, उनको हम इन पैरामीटर्स पे एस्टेब्लिश कर सकते हैं। हम प्रकृति की बात करते हैं, हम देव प्रकृति की बात करते हैं, मानस प्रकृति की बात करते हैं, तो उसमें उन प्रकृति को कैसे कर सकते हैं। मैंने द देन वाइस चांसलर जो जीनोम के थे लालजी सिंह, मैंने उनको एक प्रपोजल दिया। हमने कहा सर हमें कुछ नहीं चाहिए, हम जो हमारे पैरामीटर्स हैं, चाहे वो मॉर्फोलॉजिकल हो चाहे फिजियोलॉजिकल हो, उनको मैं इन्वेस्टिगेटरी पैरामीटर्स में लाके और वॉलंटियर सर्वे करता हूँ और देखता हूँ कि इनमें जो इस करेक्टर के लोग हैं जिनमें वात प्रिडोमिनेंट फीचर्स हैं, उनकी 5 जीनोम निकाल लें और उसको करें, और 1 मिनट में 1 बूंद ब्लड लेने के बाद मैं सॉफ्टवेयर डेवलप करूं और उसमें लगाऊं और आते ही मरीज को बता दूंगा ये वात प्रकृति का है, और हमारे निदान वाले उसको देख के आगे भेज दें, भाई जाओ तुम सर्जरी में जाओ, मेडिसिन में जाओ, कहीं भी जाओ, ये तुम्हारी प्रकृति है। अब इस प्रकृति में तुम्हारे ये जो है इस स्थान की बीमारी है, इस दोष की प्रबलता है, और तुम्हें ये दवाई दी जाएगी और रसशास वाले द्रव्य गुण वाले मिलके बनाएंगे कि चलो है इसको वात प्रभाव। जैसे अभी कल भी डॉक्टर झा जो इंदौर से थे, उन्होंने बहुत अच्छी बात कही कि हमारे मस्तिष्क में अगर ये पित्त का स्थान है और यहाँ पर ट्यूमर होता है, तो उस ट्यूमर को ठीक करने के लिए हमें कौन सी ड्रग यूज करनी है, तो उसको हमें देखना पड़ेगा। और वो सॉफ्टवेयर वो लोग डेवलप कर रहे हैं, हम लोग पीछे पड़े हुए हैं कि भैया चलो हम तो कुछ करें, हमें पता ही नहीं है। क्योंकि आज शल्य में भी अगर अर्बुद के बारे में या अपची के बारे में, ग्रंथि के बारे में लोग बात करते हैं, तो वो बातें किताबी हो जाती हैं या 2-4 लोगों के बीच में रह जाती हैं। इसको वर्ल्ड वाइड होना चाहिए, एक फोरम होना चाहिए जहाँ डिस्कशन हो, साइंटिस्ट बैठे और उनके साथ काम करने में मजा है। मैंने बहुत सारे चैलेंजिंग केस ठीक किए हैं, कैंसर के, ग्लायोब्लास्टोमा के ठीक किए, इसोफेगिल के देखे, लंग्स के देखे, लेकिन हमारे पास क्या है, हम जो उनकी एमआरआई है, जो पेट स्कैनिंग है, वो देखते हैं और केस को हम स्टडी करके डॉक्यूमेंटेशन करते हैं। हमारे पास हजारों पेशेंट की फाइल बन गई है, लेकिन प्रॉब्लम कहाँ है, हम वो जो पूछते हैं कि आपका आयुर्वेदिक पैरामीटर्स क्या है, कौन से स्टेज के कैंसर को आयुर्वेद में आपने ठीक किया। मैं उन्हें बताता हूँ कि रस रक्त मांस मेद अस्थि मज्जा में जब जाती है उत्तरोत्तर धातु में, वो जो है वहां पे वो असाध्य हो जाती है, उसके ये फीचर मिलते हैं। वो कहते हैं ये तो आपके आप बोल रहे हो ना, ये आपकी टेक्स्ट में है, इसको आप कैसे समझाओगे। हमने कहा जिसको मैं 30 साल की एजुकेशन में नहीं समझ सका त्रिदोष को, वो आपको 3 मिनट में मैं कैसे समझा सकता हूँ। आपको स्कॉलर बनना पड़ेगा। कितने लोग हैं जो आयुर्वेद के स्कॉलर बनना चाहते हैं सर। कहने को सब बोलते हैं कि आयुर्वेद बहुत अच्छा है, कोरोना में मात कर दिया उसने, और बहुत सारी चीजें हैं जो लाइफ स्टाइल से रिलेटेड है, बट द प्रॉब्लम इज दैट वन who is going to understand this one and who is going to moderate and design the Ayurvedic science on a scientific parameters, keeping your own parameters and correlating. Just translation is not possible. Just translate to Ayurvedic terminology in modern science is a very wrong attitude. If you correlate that these are the symptoms found in Ayurveda are correlating or resembling with the modern parameters or modern clinical pictures, that can be understood in this language. Otherwise, there is no need. So who is going to take this pain? This is the problem. So talking about the rights and the legal issues and other things, it is very difficult to say, sir, at my stage. Policymakers are there, they can. We can recommend, we can send, but I don't think they will discuss on that very issue. Thank you, sir, for giving me this opportunity to say something.
मुझे लगा केवल 6 ही लोग सुन रहे हैं। This is the high time to wind up.
नहीं सर, अच्छे लोग नहीं सुन रहे हैं। आपका जो ये वीडियो रिकॉर्डेड होता है, इसको हजारों लोग सुनते हैं।
तो जी फिर तो जाएगा दूर तक।
वो आवाज दूर तक पहुंचानी है सर।
What you have shared, Pandit ji, आपने जो बताया, it is a very important thing, and it will always be, Dr. My feeling is it will always be a bottom-up movement, and this is the beautiful thing about academic institutions, academic freedom. You have given us exposition of that academic freedom. Aaj, we are very grateful that you have elaborated Pavanji is also Professor Saab in Bhopal, and he is also wanting to exercise academic freedom. Agnihotri ji is also in the academic environment. So we are all in that space and saying a bottom-up approach is what is required. You have given us a very extensive and a very clear view of where the difficulties are. And आपकी बिल्कुल अंत में जो comment आपने बनाया, the comment you made, जी, कि people will listen to this. I think we are very grateful you have taken the time to share your thoughts and such clarity, ji. There are difficulties, and those difficulties you have distilled very nicely. And I hope, and I'm grateful that you were there listening to yesterday's Cancer Wali Baat or aaj, the issues about the legal issues. And we will discuss this tomorrow also, the legal aspects of these things. So it is a nice continuation between yesterday's cancer aspects and today's what Harish ji has raised, and what you have given us will connect us very nicely with what will happen tomorrow. Now we are approaching 9 बजकर 10 जी, 9:10 पवन जी, अगर हमारे साथ
सर कल 2 वेबिनार हैं,
2 वेबिनार,
कल 13 स्पीकर हैं कल.
बढ़िया जी.
So it is better to conclude the webinar.
Thank you, Pavanji. Thank you for. Once again, I want to thank Pandeyji for introducing Anilji today. Bahut bahut dhanyawad ji. And I'm grateful to Archana for joining us today from Kerala. And also special thanks to Harish ji in Toronto. Harish ji, thank you for touching that one point that has really made Pandeyji come out with some very, very clear suggestions. So, bahut bahut dhanyawad ji. Bahut bahut dhanyawad. Pavanji.
Thank you, sir.
Thank you.
Thank you very much. Now
Thank you for bringing all of us.
Professor V.K. Agnihotri ji for his concluding remarks.
Thank you, sir. Thank you. Namaskar, sir. We are delighted with all the good inputs of today's webinar, and especially our greetings and thanks to Dr. Anil Kumar and as well Dr. Archana ji. Both presented well on the today's topic as we were commemorating the World Radiography Day. So these were the basics, but otherwise we gone up to very distant area where all the suppressive problems which were always there for a couple of years or decades of years. So let us all come together and decide either we proceed simply with the Vishuddha Ayurveda treatment, Akhil Ayurveda, or we should get the integrated concept so that suffering humanity must be served by the best possible manner. Because if the proper anesthesia will not be given, the surgery will not be possible. So was the case with the other systems, delivery, LSCS, everything is there. So these are the very vital points, and our authorities which are responsible for making such decisions and some sort of softness must come forward and to decide with the such persons like Professor K.K. Pandey sir and other persons that what may be the say midway, what may be the way out so that the crisis may be rooted out. So these are a few words, and I thank all those who joined today our platform and also participated in our discussion along with Dr. Harish Ramaji, and our vital discussion went on up to 9 o'clock. I was scared that only 2 speakers were there, so it might have concluded by 8:15 or 8:30, but still good discussions are always awaited, and it came on today. So thank you all. Thank you very much. And again over to Pawan Sharma. Namaskar sabko. Pranam.
Thank you sir. कल 6:30 बजे जोड़िएगा. उत्तराखंड डे, हैप्पी उत्तराखंड डे in advance, Agnihotri ji.
Thank you, sir. Thank you.
Thank you very much. Tomorrow we will be joining at 6:30 to 7:30 Uttarakhand Day, and 7:30 to onwards legal issues, in which 7 speakers are there. So welcome. Good night, sir. Good night.
Good night.